Good day to everyone out there. I welcome you for our today's session on lasers and proctology. I have the great honor to introduce Roman from Switzerland. I should start with Biolytic or how we got here, because on the laser 10 years. Actually, hemorrhoidal treatment was one of the first treatment modalities that we have introduced. And we have many countries have seen a lot of public. The laser use was extended from the hemorrhoids to anal fistulas, sinus pilonidales. We today treat fissures and also suppurative. Today's session is dedicated to the so-called laser hemorrhoidoplasty. And before we Dr. Roman's presentation, I would like to about using this instrument, because we want to exchange as good as possible. And due to the limitations of Corona, I think we have to use this system by adding questions. And I will now share with you my screen and show you how we can do this. Just a moment. What you should see now is of your PC. As you can see, you have here the section questions, and these questions will be for me and Dr. Roman. That means you enter your question and send it to everyone. And then after the session, after the video that will be displayed for approximately 20 minutes, you can write your questions throughout the whole happening, and we will then identify the questions and answer them accordingly. You will understand that 300 people in the loop that we cannot open the microphones. Therefore, the only chance to interact with us for you is to ask questions here. So, I can see that we have already 200 people in the loop. Normally, it takes a little bit. People get set with the system. Nevertheless, the approach is 20-21 minutes talk from Dr. Roman towards 10-15 minute session. And I would like to get you already now to inform you about the next procedure. We'll have more to come tomorrow, on Wednesday, next Monday, and also throughout next year, because as we all know, now that soon. After the talk and after the session today, you'll receive a little questionnaire. Just 4 questions, don't worry. And we would be grateful if you could answer those questions, because they will help us to start the next session in next year, again with Dr. Roman, to answer those who could not answer or be answered today. So I hope you all grab a cup of coffee or maybe a tea. Now to Dr. Roman's talk. So I will webcam for a moment, and off we go.
Today I would like to share with you some of my experience concerning the laser hemorrhoidoplasty, LHP, the way I do it since 2017. And the question is this laser announcing a major change in terms of lower pain and better results? I was asking to myself during my 20 years of experience in hemorrhoidal surgery, why the classic Milligan-Morgan technique still remains the best one, despite of the pain, the extraordinary pain and discomfort it provokes, because the techniques, the other techniques try to be less painful, but for the effectiveness there is still a major weakness. So that's why people are trying to invent new methods which try to peer the results of the classical intervention, but with much less pain. There are so many studies in the literature, if we look up, comparing always the classical technique with some other techniques, laser hemorrhoidoplasty, rubber band ligation, THD, ultrasound, and whatever. We are always trying to compare the classical technique with the newly introduced technique. In all these studies, we can see more and more that the laser hemorrhoidoplasty has become to prove as a safe and effective technique with a real reduced intensity of duration of post-operative pain, and nevertheless good results. The most interesting for me is the recent study of our colleague, Professor Thomas Poskos. It was a double-blind randomized control study which compared the laser hemorrhoidoplasty with some other two techniques, the classical excisional hemorrhoidectomy and sutured mucopexy. This is interesting because he did it separately, but as for myself, I advocate the association of a short mucopexy, like I will discuss later, with the laser technique. Short thing about the laser used in proctology. I used only the LHP, not the HELP technique. So therefore, I use the 1470 nanometer wavelength, which is, like you see here, the best choice. Why? Because to control the absorption in water and blood, to control the action, this wavelength allows only 2 to 3 millimeters range of action. So this is helpful because we don't harm the internal sphincter. We can keep us at a distance. So you see this wavelength of 1417 proves to be the best one, at least for the LHP technique. I will discuss now what I did and what I am doing. For me, the indications started from a second degree with no sufficient response to rubber band ligation, to segmental or circular second and third degree hemorrhoids. But I had a lot of patients with the fourth degree where I used combinations with other treatments like mucopexy, as I said. Of course, as counterindications, we have proctitis and acute abscess. I performed all my operations in the Clinique CIC in Saxon, in Valais, in Switzerland. And as you see, most of them were outpatient. I had some patients who had some other comorbidities, which forced us to keep them hospitalized, as to say. As for preoperative preparation, I used an enema 1 hour before and an optional single-shot antibiotics like depicted here. Of course, I always draw attention to the patients that the final results are assessed only after 6 weeks. In the LHP technique, we introduce a laser fiber into the hemorrhoidal node, and laser energy is applied. Of course, the aim is to absorb the energy of the laser by the hemorrhoidal tissue, which will lead to the destruction of the hemorrhoidal vessels, followed by a fibrosis that will shrink and reduce the total hemorrhoid. So practically, the aim is to shrink the hemorrhoidal to transform the vascular tissue into a fibrotic one. The processes of shrinkage is a direct and immediate one for a third, and the rest of 2/3 will arrive during the next 3 to 6 weeks to the final result. That's why we have to communicate to the patient that after the operation, the edema should be even bigger than before, and he or she shouldn't worry about this, because the complete shrinkage will end up at 6 weeks after the operation. You see here a small animation, a short animation about the technique. Before, we used the ligatures in the classical technique, which were so painful. Now, with the laser technique, we can avoid sutures in the anal canal, which leads to much less pain. Therefore, we will do only a small hole just to insert the needle. The laser is like a needle, and we can just press the pedal to apply the energy. Like we said before, the wavelength of the laser allows us to keep at a distance from the sphincters, not to harm them. So practically, if you want, instead of cutting and excising the hemorrhoid, we will transform it in place, and we will leave it in place in order to shrink in the next 3 to 6 weeks of time. During this period, the patient will experience some inflammation, but not a big thing. And you see, finally, we will have much less hemorrhoids, smaller volume, and a fibrotic tissue. This is an image of one of my operations. It was taken with a mobile phone. You can see that I introduced the laser needle, which has an additional light. We won't see the laser. This is only the light to guide us through the tissues. And one of my assistants tells me every time the energy I use, because it's very important to have an exact image of the energy you used for the hemorrhoid. You see, we check all the time the energy on the screen. This is the needle, and as for the energy, normally we should use 150 to 200 joules for the second degree, 200 to 3 or maybe 400 for the third degree. I have to admit that for the fourth degree, I used even more than 400 joules for a hemorrhoid. Like I already mentioned, I will advocate a short distance mucopexy, 2 or 3 stitches, in case of a large prolapse, of course. And a mucosal prolapse, in fact, is very widely encountered in the hemorrhoidal disease. And there are studies who say that if we fix the mucosa, if we take it back inside and fix it to the submucosa, the reoccurrence rate will diminish. On the other hand, I use the same entry port at the skin or at the junction with the mucosa to treat also the marisks at the external side. There are some studies who already sustain my affirmation that mucopexy leads to less post-operative pain. In fact, it is logical. We diminish the blood supply And that's why the post-operative edema will be less important, and therefore maybe the post-operative pain would be less. As for myself, I started my laser techniques without mucopexy, and then since I've started the mucopexy, I could have noticed at once a good outcome concerning the post-operative pain. On the other hand, hemorrhoidal artery ligation is important. Practically, there are already studies who show that Doppler is not useful anymore. In fact, if you go upwards the hemorrhoid, 0.5 centimeter, and you put a stitch, an X stitch there, you will catch for sure the artery. You don't need a Doppler for that. So I will start the mucopexy, the short mucopexy I advocate for. I will start it as a hemorrhoidal artery ligation a little bit upwards from the hemorrhoidal mass. And this I will do, of course, after the laser treatment of the hemorrhoid in the anal canal. It is not logical to do first the mucopexy and then the laser. You do the laser first in the anal canal. You cover all the surface needed, and then you go up inside. You stitch the artery, and you continue by a short mucopexy. At least this is what I'm doing. The immediate shrinking effect is around 30%, and of course, local reaction is beginning to create a new connective tissues even for 5 days in post-operative. The shrinkage will continue in the next 4 to 6 weeks. That's why I have to prevent the patient that the final discussion, the final results will be obtained after 6 weeks. Post-operative management. I did all the patients in outpatient clinic. Let's say after 3-4 hours, they quit the clinic. I have a protocol which describes every step, how to take, what ointment to put, what time, how many times per day you should take the sitz bath, things like that. Why you shouldn't bother if you have some small pain in post-operative, why you shouldn't bother if you should have some bulging of the external hemorrhoids, because here most of the patients would think that the hemorrhoids would have come back. Of course, the edema is painless and is vanishing with several days. In the first 1, 2, maybe even 3 weeks, the patient could experience slight bleedings and, of course, a fetid secretion sometimes. I will always see the patient for the first time 7 days in post-operative, and then in 6 weeks. Why 7 days and not 4 days and not 3 days? This is not to protect myself to see a patient in pain. I'm joking here. But the suppurative complications, anal abscess and all that stuff would appear only after the 5th day normally. That's why I'm trying to see my patients at 7 days, when most of them, I would say, they are already painless after 7 days. I always use sometimes a perineal block, but I use an intersphincteric anesthesia with a long effect. And this, I could say, helps the patients not to have pain. There are so many patients that don't have pain in the first 2 days, Normally they go to stool in the second or third day, even if I give them laxatives. And they say, doctor, I experienced some pain when I went first time to stool in post-operative. That's second or third day, but they didn't have pain before post-operative, which is amazing for us who have been doing this for 20 years and who have been experienced the look, the glance of the patient with pain that looked at you like at the biggest enemy on the occasion of their first control in post-operative. I have even more now than 356 consecutive patients. I started in January 2017. I used only LHP, like I said, most of them in outpatient. We evaluated retrospectively the operative time, the post-operative pain and complications, the resolution of symptoms, and time of return to daily activities. Average operating time was about 20 minutes. This is fine. You have 3 packages of hemorrhoids. You do 3 laser and 3 mucopexies. Not a big thing normally. We didn't have a significant intraoperative complications. And the post-operative pain score was really very low. Like I said, the patients were delighted and surprised about the lack of pain in post-operative. No important bleeding. We had no important bleeding, probably because also due to the mucopexy I'm doing. I don't know. I had only 3 perianal abscesses requiring incision, like I said, normally after the 5th day in post-operative. And most of them came back to daily activity 5 to 7 days after surgery. I give them 2 weeks off normally, but most of them use only 1 week. And as for the women, I had a lot of women patients, female patients, that went back to work on Monday after their operation for hemorrhoids last Friday. So the 3rd day they went to work. Of course, female patients are, as we all know, much more resistant to pain. So as for myself, LHP offered me a large efficiency in those selected patients, a very low post-operative pain. The idea that you have only very small perianal wounds, no special anal hygienic measures, and a very low surgical time. As for myself, I am very pleased with this method. I will continue to use it until a new star will be discovered. And I said star with 1 R, not with 2 R's, okay? Thank you for having my presentation and looking forward to interact with you. Thank you.
So, dear everyone, this was Dr. Roman's contribution. I can see that we've already received a couple of questions. I will now bring Dr. Roman so he can moment. So, hello, Dr. Roman. Do you hear us? Because I think you're muted for a moment. Dr. Roman, can you hear us? I think you're muted.
Yes,
Now it's possible.
Can you hear me? Hello?
Yes, wonderful, wonderful. You know, I've received quite a few, and one of the first questions that came in was the question, if you treat all the hemorrhoidal nodules in the same session.
Thank you for the questions, and hi everybody. Thank you for attending this presentation. Well, of course, I always try to do only one session. For a patient, this operation is really very important. Maybe it's the first surgical event of his or her life. So we're trying to do it once. And yes, I'm treating normally 3 or 4 packs of hemorrhoids. And at the same time, I try to treat the anal prolapse, the mucosal prolapse, and of course the skin tags, the marisks, in the same session. Yes.
Okay. Another question would be, do you use treatment after each pile? So not just for the whole session, but after each pile, do you use ice water?
Yes, I'm trying. At the beginning, I did not use, but now it's a matter of common technique to use iced water after each pile. So you just put the laser on, you put the energy you wanted, and then you apply the cold water, the iced water.
And you applied with some gauze, which you put into the sterile water, and then you apply the gauze onto the surface of the mucosa.
Exactly. There are some techniques described that use ice cubes in a glove or things like that. For me, it's too complicated. If you have really a nice saline, very cold, and you just put the gauze in and then you apply it to the hemorrhoid, it will freeze your finger. So it's good.
Okay.
If it freezes your finger, it's good for the hemorrhoid too.
Okay. Another question would be, why do we need the mucopexy? The question is, I think, what is the effect? What is the effect of just mucopexy? Can you see this? Have you ever mucopexy?
Yeah, I tried to demonstrate here in my presentation that I'm an advocate of the mucopexy in all situations. Well, at the beginning, like I said in my presentation, I started without mucopexy. It was good, but then I read some studies, I've heard some techniques, some colleagues speaking, Dr. Postkus, when I met him, he told me about that, and I was interested to see. In fact, it is logical. If you put off the blood flow, if you reduce the blood flow in the hemorrhoid, the post-operative, the post-treatment edema is lower. Therefore, the pain should be lower. And even instinctively, when I did this, I saw that the patients in which I did this went better and without pain or with less pain. So I advocate this short mucopexy. In fact, you should think that it is not only mucopexy. If you start half a centimeter above the hemorrhoid, practically you will catch the artery too. And you will apply the excessive mucosa. So you will do 2 things at the same time. You will do the arterial ligation and the plication of the mucosa, which it is proved to be to increase the reoccurrence.
Describe the positions of the stitches. You would say that you will go the first deep stitch above the hemorrhoid?
Yes, it's like you said. It's inspired, if you say it's like the THD technique. You start above, so from inside to outside. You start above, you do a double stitch in order to catch the artery, and then with the same suture, you go in a spiral 3 or 4 times towards the external, of course, not very close to the dented line, because if you go there, you will have pain. That's for sure.
So to speak, 2.5 centimeter deep stitch above the linea dentata, then the next one a centimeter below, and the lowest one 0.5 centimeter above linea dentata, so to speak.
Maybe even a centimeter above the linea dentata.
Okay.
Maybe even a centimeter.
That's fair enough. Yeah. Then 2 questions which linked to each other. The question was maybe a bit too early, but what about complication? And someone is referring that the person has regularly a thrombosed pile on the 7th day of post-op. Did you experience that too? And what can you do to manage that?
Yes, of course I experienced that, and it's quite regular, I would say. We might think of two explanations for that. Either you do a too short a mucopexy, and you leave enough blood in the lower part, which could clot afterwards, so could trigger a thrombosis, or maybe you do it too much. I don't know which is the explanation. A third explanation would be, and I think it's the correct one. I saw that, I would say frequently in patients who were constipated in post-operative. If they are not constipated, they won't do this thrombosis. Of course, if you are constipated, this is an extra stress for the evolution in post-operative. Of course, the tissue and the area is inflamed, is very sensitive. And if you add a new stress on that, the constipation, of course, you could develop a thrombosis. So my answer is yes. I encounter this very often to the patients who are constipated. Maybe they are not, I give them 2 laxatives in post-operative, but some of them, they don't take it or they don't understand. Even if I have that protocol which says very clear you should take that, when and how. But for the patients who are constipated, they will probably develop a thrombosis, and he is right, our colleague, around the 7th day in post-operative. Most of them, yes.
Another question would be, thank you very much, Dr. Roman. Another question would be, do you ever combine LHP with the classic approach? For example, if a patient has a 3rd-degree hemorrhoids and a huge prolapse that would normally be addressed by Milligan-Morgan, do you combine those techniques?
Never with Milligan-Morgan, maybe with Ferguson, but never with Milligan-Morgan. So closed technique, not open techniques. Milligan-Morgan, I did a lot in my time, in my early time, but now I'm not doing it anymore. Even though it still gathers the highest rate of success in good hands.
Fair enough. Happy to hear that. More questions coming up. Did you ever have problems with post-operative incontinence?
No.
Clear? No.
Here, there's a discussion here. You have to very well assess a patient before the operation. If the patient is incontinent, it should be incontinent before. And then in this case, either you don't operate him, either I would do only a pack or 2, the biggest one, and I will leave some cushions inside in order to preserve his not consistence, continence. Okay, so you already know a patient has problems. If a patient has incontinence problems, you'd probably abstain from operating him.
Okay.
You don't do him a good thing.
The next question would be, if you have a local acute hematoma, some stitches on or just use freezing and compression?
No, I'm a surgeon. I will put stitches. I don't trust only. Yes, if you have an accident like that, you see it bulging, you have to put stitches very rapidly to stop the developing of the hematoma.
Okay. Yes. Further question: laser application can damage mucopexy sutures. I think the question is okay, but you always laser and then you proceed with the mucopexy, right?
This is logical. Not to damage the sutures, you have to do the laser before, and then the final thing you adjust with the mucopexy.
Got it. All right. If you have external hemorrhoids, you have a big chance to have external thrombosis after LHP. If you don't have internal hemorrhoids, you have no. Just a moment, I have to open this up. You don't have external hemorrhoids, you have no problems with external hemorrhoids. I think the question is, if you have external hemorrhoids without having hemorrhoids, what can you do?
In my opinion, it's very rare or maybe impossible to have only external hemorrhoids. You should have first internal hemorrhoids, and then you will develop external. This is the logic mechanism. So this hypothesis of having only external for me is not true.
Okay.
So if you have external, you should have also internal, and you have to treat the internal. And for the external, of course, you should treat them if whether these hemorrhoids, these external skin tags are really bulging, and they could trigger afterwards maybe a chronic anal fissure. Because if you have a big skin tag, that will act like a sentinel hemorrhoid. It will tear at its basis, and it will entertain a chronic fissure.
Okay.
So big, you have to treat it.
Get it. Would you do LHP in hemorrhoids, and have you any complication as stenosis?
I didn't understand. I would do in what degree?
Yeah, sorry. What would you do for 4th degree hemorrhoids and complications as stenosis, for example?
No, why should I have stenosis? Because in the anal canal, I do only the laser. And
okay.
For the external hemorrhoids, I would never cut them for the skin tags. So if you don't cut them, you couldn't have anal stenosis, cutaneous stenosis after that. Because
Right.
I don't know if I mentioned, I think I mentioned in my presentation that I use the same hole, small hole, which I use to treat the internal hemorrhoids. Then I turn the laser towards the marisc, the skin tag, and I will go inside the marisc and push the pedal again for to treat internally if you want the skin tag.
Okay.
This will lead to a bigger edema of the external hemorrhoid for some time, but I had really very, very good results after 6 months, even for the 4th degree.
Interesting. But you would recommend to inform the patients before if you remove the skin tag, because then he will have most probably more pain than just with the LHP technique, right?
Right. I will inform the patient that I would never cut his mariscs, especially for the female patients. They are presenting at the praxis at the doctor just to cut the external. That's what they are bothered by. But I explained them that in fact the internal hemorrhoids have to be treated, and only if they don't attend a beauty pageant of the anus this year, we should try to cut them. Otherwise, I won't cut them.
Okay.
And
fair enough. Then we have a question which is very enticing for me. The person is asking, please tell us about a possible local anesthesia. Are you using a pudendal nerve block?
Sometimes I use a pudendal nerve block, and sometimes I infiltrate with long-acting anesthetic between the sphincters, an intersphincteric infiltration, which is, I find, very, very effective. Since I'm using that, I see that the patients don't have pain until their first stool, which is normally 2 days after the operation. They describe no pain until the first stool, which is amazing for me.
Happy to hear that. I think another interesting question would be, is there any essential difference from the to the radio frequency method? And I don't know if you can answer that, Dr. Roman. I can say a statement to this because whenever laser are used, then radio frequency is used and vice versa. And my experience is that, as you have seen in the report from Dr. Roman, that we apply 300, 350 joules per pile, whereas radio frequency you can find in the literature 1,000 1,500, 2,000 volts even. So it's actually almost a factor of 10 more energy. And so far, there is not a comparative trial to compare radio frequency with laser. So I think the more precise, and you need at least less energy than, for example, if you use a radio frequency generator. Did you have any experience, Dr. Roman, with the radio frequency?
Yes, I have some experience, but I used radio frequency, I think Elman, I don't know, I don't remember the name, maybe it was Elman or something like that, to cut the marisks. And I remember it was 10 years ago, never used it for inside, okay, for the internal hemorrhoids. And as far as I remember, it's lower temperature, but everything is related to the quantity of energy, to the amount of energy. So this is what we have to, maybe when I saw images, I recently saw some images of technique with not the ultrasound, the
radio frequency.
Radio frequency, and I saw the whitish mucosa. The whitish mucosa, which at the end of the treatment, it becomes white, really white. And for me, it's too much energy, if you ask me. Because in my early cases with the laser, maybe when I overdid it, I saw a white mucosa. And then at the first anoscopy, the mucosa was damaged. So, like I say, I always say to my colleagues who visit me, you have to finish the hemorrhoid, so to stop the energy, having the sensation you haven't finished. Not to do too much in order to see the white mucosa. If you see the white mucosa, it's too much, in my opinion.
I understand, especially the approach as a surgeon, you always want to have your result right on the spot. And here it's, as you described, it's a little bit wait and see. The final result is after 6 weeks. Another question would be, did you give any elementary recommendation for your patients, like stool softeners, for example, psyllium for preventing external hemorrhoids?
Of course, I prescribe 2 laxatives in post-operative time, 2, just to be sure. Okay, and I say it's simple for the patient. If he sees he goes to diarrhea, he could diminish the quantity. There's no problem with that.
Okay. One question which is for me personally very, very well is how do you check out the position of the laser probe in the hemorrhoid?
But this is, you saw the images, we have that guiding light, which you can even select red or green. Personally, I prefer green. So this light is always visible. So you can position yourself in very easily by regarding this guiding light. And then you press the pedal.
I might add that normally you try to be in parallel to the mucosa or sphincter muscle, and you can use the laser fiber a little bit to the surface to see where you are, and then
without
in
pushing,
parallel fashion, and then you activate the laser. If not, you might generate something like tiny necrosis, a white spot, which is smaller than after rubber band ligation, but you would see that you are too superficial when you have a whitening, a blanching of the mucosa. Okay, I think we have gone through most of the questions. I promised everyone to you that you wouldn't be occupied too long by us. So after the session, you will receive a little questionnaire, just 4 questions. You can ask us any question which has not been properly answered. We will have a new session the next week, again with Dr. Roman. I'm happy to announce this already. And I have to say, best regards from Dr. Avramovic from Romania to you, Dr. Roman. He asked me. So, I did that. I did my duty. And I would like to thank every one of you, especially you, Dr. Roman, for attending this session. I hope it was short enough, not to be boring, but still long enough so everyone got a little hold of the laser. We'll proceed tomorrow evening talking about post-push LHP experience, about on next Monday, and on Wednesday this week about sinus pilonidales. So stay with us, stay tuned, and I wish you a very nice evening. Get home well, and let's stay in touch. Easy time. Goodbye to everyone.
Thank you, everybody. Thank you.